Thank you all for joining this presentation. And I like to try to have interactive presentations. So do some polling, ask you to write some stuff in the chat. And if you feel up to it, by all means, unmute yourself and just ask any questions, blah, 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 okay? And one thing about ethics, there are no wrong decisions. Well, most of the time. Anyway, so let me start this presentation. Okay, so, all right. So first thing I want to say is that I want to make sure everyone knows how to contact the ethics committee at UMMC, okay? We have consultations 24/7, and here are the contact numbers. My cell phone number is on top. You could call the page operator. I don't even know why I have that line on here anymore. Or you could place an order in Epic, or probably the best way is to Tiger Connect me. You'll get me even if you connect to UMMC Ethics or myself, Henry Silverman. Okay, all right. So the first case, the question is, are decisions being made in the patient's best medical interest? Okay, so the patient is a 63-year-old female with past history of hypertension, CVA, obstructive sleep apnea, who is admitted to UMMC with an MCA stroke, and she underwent a decompressive hemicraniectomy due to the midline shift. And she is also status post treatment for a ventilator-associated pneumonia, which means she's also intubated. Okay. Now, what prompted the ethics consult was that now there's concern for infectious fluid collection involving the bed of the craniectomy and ventriculitis. The medical team is asking the healthcare agent who was appointed via an advance directive documented by the patient several years ago, and the medical team is recommending an LP in order to ensure that they are administering the correct antibiotics. However, the patient's healthcare agent has refused consent due to concerns regarding the invasiveness of the procedure. The healthcare agent is also refusing a trach and a peg that was also brought up in the meeting for, obviously for long-term placement. And the POA believes that the patient can recover. Okay. So, right. So what should we do now? So I'm going to get you started. Why don't you write in the chat box, what do you do now? And Danica is monitoring the chat box. If anyone cares to write down their thoughts.
Dr. Silverman, are you able to go back to the slide with the vignette just so we can review while we're thinking?
Oh, okay. There you go. All right, very good. So, okay, right, 63-year-old female.
Okay, I have one thought here. Does this patient have a pre-existing advance directive?
Yes, she does. That's a good question. As I somewhat rapidly said, she has an advance directive in which she appointed the POA or the healthcare agent, who is a friend, and she appointed her friend to be her healthcare agent. And now, the advance directive did leave instructions saying that if she was in a irreversible coma or PVS, that she just wanted to have relief of suffering and to die naturally. Okay, so What do you think about that now? So she left instructions saying that if she was in a irreversible coma, okay? So
Okay.
are those instructions good enough? I guess the issue in my mind is that the POA thinks the patient can recover. She doesn't believe the patient is in an irreversible coma. So this is where, yeah, what's her code status? Well, her code status is full code. Is full code.
And Dr. Silverman, my question is, I guess if the POA believes that she can recover and that the medical team believes that she has this potential, potentially fixable issue, is she allowed to make this sort of decision to prevent,
Yeah, the patient is neurologically, right, not in good shape, okay? A stroke, midline shift, and she's not waking up, and now there's a concern for an infection, and she's refusing the LP, blah, blah, blah. So again, the question is, are decisions made in the patient's best medical interest? And one could also say that she's not following the instructions in the advance directive. So we're at a standstill here. She's the agent. And now if we wanted to push it, what could we do? Obviously keep on having discussions, but
another good point here is brought up in the chat box. What's her neurologic prognosis thought to be?
Right, yes. So, well, I hope there isn't any budding neurologists on this call, but neurology, and to be fair to them, it's really hard to make a declarative prognosis. However, it's poor. It's
Sure.
poor for her to wake up. I
think it'd be easier if the patient had said what her goals, if she were in this situation, what her limitations would be for recovery, like if she was to recover to a functional state, but not back to her baseline or something like that. Anna also brings up a question. Why does the POA believe she can recover, and what discussions have the teams had with this person?
I've had many discussions, and what could I say? Families or friends are always thinking that the patient could recover. I'm caring for a patient in the VA. I won't bore you with the details, but let's just say the patient is not doing well, and I was talking with the wife, and the wife admits the patient is deteriorating, but feels that something else could be done. Okay, are you sure nothing else could be done? Okay, so it's hard for, what could I say? It's hard for family members and friends to to let go. It really is. Fortunately, in that case I just mentioned, she asked for a second opinion and asked if I could call this ICU doc at St. Agnes. So I did, and the ICU doc happens to be someone who trained here 10 years ago. So I made a good connection, and hopefully she has a lot of trust. So, all right. Let me just say that good questions about the advance directive, and it would have been good if she put in her goals of care, blah, blah, blah. But, uh, there's been a recent turnaround here with advanced directives. I think advanced directives are good to appoint an agent, but in terms of leading instructions, listen, we all don't know how we're going to die and what disabilities we're going to have. So it's hard to predict what we would want when we get ill. And even if we think we know what we want, our minds could change. So there's been some recent pushback on this whole idea of leaving instructions in an advanced directive. Okay, well, let's continue. Right. So now, what to do now? Good questions in the chat box. Thank you very much. Now, let's, so they got an ethics consult, and I had a brief telephone conversation with the healthcare agent, and she said, everything is fine with the interactions with the neurology team, and that she wants to take everything one day at a time. She reiterated that a trach and peg could be performed when the patient is medically stable to have these procedures performed. When I asked about the LP, she said she has her own source of information that's guiding her decisions. All right, so let's just say it wasn't a very long conversation. So let me ask you, let me do some polling here, okay? And so let me put up this poll. All right, so how much should the medical team press for the LP? Pursue aggressively, as it is important to obtain, moderate persuasion, or would not pursue too much. Okay, when we give about 15 seconds, I have one person so far. All right, good. 4. How many people want to call? 16. Let's get, all right, okay. Let's get a few more. This is anonymous, okay? I don't know if that helps. All right, let's get one more. Okay, 5 seconds. 5, 4, 3. I'm not going to take off. Okay, 2, 1. Okay, so, all right. So here's the results.
50% said moderate persuasion, 30% said would not pursue too much, and only 20% said pursue aggressively.
Okay, good. Diversity of opinion. So our recommendations was to, it appears that refusal of the LP, that's not really going to set back the patient's best medical interest significantly, although this could change if she develops sepsis or sepsis continues with progression to shock. However, performance of a tracheotomy is standard medical care and needs to be performed in a timely manner. It does appear that the healthcare agent will, when she convinced that the patient is medically stable, will provide consent for the trach and the peg. However, if the healthcare agent refuses treatment that is thought to have a potential major adverse effect on the patient's best medical interest, then legal measures might be warranted. Okay, so fast forward 2 weeks later, her exam is unchanged, and the endotracheal tube and her feeding tube in place for 30 days with no meaningful improvement or chance of recovery, where she could be safely extubated or be able to swallow on her own in the foreseeable future. And the attending wrote a note saying, I met with the healthcare agent at the bedside. The POA has declined to provide consent for surgery tomorrow and is requesting again that the procedure be postponed for non-medical reasons. The attending explained that an unnecessary delay in the procedure could prove harmful to the patient. Will re-engage the ethics consult for today. So what, let's see, what's the next slide? So what's the next steps here? She's refusing the trach and the peg. And she wants this patient to go to, yes. On the other hand, she wants the patient to go to Midtown for long-term care. So we seem to be in a contradiction here.
Sorry, Dr. Silverman, just to clarify, so she wants the patient to go to long-term care, but without the trach and peg?
Right, yeah. So there's a disconnect here, right? So.
And we got a question, why does she not want the trach and peg? Does she have specific reasons for that?
Well, that's a good question. And, she doesn't think let me just see something here. Right. We advise the attending to discuss with the POA that a trach peg represents standard of care. And if she is unable to provide consent, then the hospital may decide to seek the input of the court. Okay. Now, she doesn't really give good reasons. I mean, she keeps on saying, I want to wait until the patient is stable. Okay. POA at bedside states, sorry. So the POA keeps on saying, I don't think the patient is stable. And I said to the attending, listen, talk to the, as I said, talk to the POA and just say, listen, we have to do this trach and the peg, and we wish that you would provide consent, but if you don't, we're going to go to court and see what the court says. Now, most likely, the court, essentially, I'm advising to go to the court, get another guardian, get a guardian appointed. What usually happens is the court will appoint her as the guardian, but the court will give her instructions. Now, I said to the attending, put that option on the table, and when she hears that, hopefully she'll relent. Okay, and that's what she did. POA at bedside says that she now consents for the trach and the peg and procedure planned for Monday, January 3rd. Okay, so she's somewhat malleable. Okay, all right, case continues. Okay, January 25th. The attending spoke with the patient's POA regarding discharge planning. Per the POA, I feel the only place that's going to be good at this time is Midtown. I am not considering any other place because they won't have access to an ICU. The POA was advised that the case manager would follow up with Midtown. However, if Midtown is unable to accept, then we would need to discuss over options. And the POA says, okay, let's see. Case manager says, since patient is no longer requiring ICU level of care and has minimal hospital needs, at this point, case manager is going to initiate the process of placement in an appropriate long-term facility, whether it's Midtown or not. The attending called the POA to update her and notify her that she will be getting a call from the case manager. POA expressed many concerns about the patient's stability and appropriateness for a lower level of care. The attending explained the process to the best of his ability. Also wrote, ethics involved in this patient care earlier in a hospitalization and will consult for additional input. All right, so now, what do we do now?
Feel free to type them in the chat box or.
Yeah, yes, right. Well, either unmute yourself or the chat box. Would love to hear your voices too if you're tired of writing.
Well, I do have a thought, Dr. Silverman. It kind of seems like recurring throughout this a scenario, this POA has a kind of misunderstanding of what stability means, at least in medical terms. I don't know if there's a disconnect with like educating her, but it seems to be a similar kind of problem at every step is a misunderstanding of what that means.
Right, at every nodal point, the same thing, right? So I was thinking about that, and couldn't have said that better myself. So I decided to take a different track, okay? And I wrote in my note, I wrote in, what to do now. I often look like that. So our recommendations was further discussions with the POA, right? And then I wrote, they want to ask the following questions of the POA. Have there been any experiences that cause you to lose trust in the healthcare system? Also, many patients experience racism in their healthcare. Are there any experiences you would like to share with me? POA is African American. Are there any experiences you would like to share with me? What are your thoughts about that? Should we be asking those questions? Well, let me, right. So think about that for a second. I inquired of the POA whether I said, ask the POA if she wants a second opinion. And I said, also brought up about the court system. But I do want to focus on these questions here. Okay. And so I want to just say that, since COVID came along, there's been, guidelines about inequities in healthcare and discrimination bias, racism, and how we deal with our patients unconscious bias. Okay, attention, doctors, here's what an anti-racist approach would look like. And then this resource, liberation in the exam room. racial justice and equity in healthcare. Okay, I'll get back to this liberation in the exam room, but let me do a poll here. Let me ask you this question here. How comfortable do you feel asking patients about race, ethnicity as a factor in access to care or treatment when, the goal of the policy is to reduce existing racial, ethnic inequities? How comfortable are you in asking those questions? Okay, I got 6 votes, 8 votes, 10 votes, 10 out of 16. Okay, let me get one more vote. 5, 4, 3, 2, 1. Okay, end the poll. Here's the results.
50% had some degree of comfort in dealing with these issues. In fact, almost 10% felt very comfortable. And about 50% said they would have some degree of discomfort in asking patients about race and ethnicity.
It is an issue of how comfortable we feel in addressing this question with our patients. And so when I wrote this in my consult note and shared it with members of the ethics committee, someone said, Henry, did she express issues about racism? And I said, no, but we can't depend on patients to tell us that. We have to be somewhat proactive. And that would be an anti-racist maneuver, is to be proactive and ask in as sensitive a way as possible. In the exam room, liberation in the exam room, questions for the first visit with the goal to make the implicit explicit. You could ask questions like, many of my patients experience racism in their healthcare. Are there any experiences you would like to share with me? And have there been any experiences that cause you to lose trust in a healthcare setting? And you could also bring up, do you feel there's an issue about race and discrimination? And then you could also ask, if I miss something important or say something that does not feel right, please note that you can tell me immediately and I will thank you for it. Okay, so it's something that we really need to approach. Here are some resources, and I'll share the slide with you, but there are a lot of resources. And let me give another example. So a tale of 2 patients, both cisgender women, meaning that they take the gender that was given to them at birth, as opposed to transgender. Patient 1 is a 45-year-old woman admitted for management of a sickle cell crisis. This is her 3rd admission for sickle cell in the past 6 months. She works as a cashier at a discount superstore. Patient 2 is a 45-year-old woman admitted for surgical repair of a right humeral fracture. This is her 3rd fracture in the past 6 months, preceded by wrist and ankle fracture. She is a professor of literature at a local university. Let me now ask you, let me poll you again. Okay, so this poll is, this question here. So which patient do you suspect may have a substance use disorder? Patient 1, patient 2, both, neither. Okay, 7 have voted. Let's just get a few more votes. Okay, let me stop here, share the results.
The predominant response was neither. Almost 80% voted for this response. Only 10% voted for patient 1, and approximately 10% voted for patient 2. Nobody picked both.
Do you think is more likely to be labeled as having a substance use disorder? Let me stop the poll in 5 seconds. Okay, here's the results.
We see that 90% thought that patient 1 would be labeled as having a substance use disorder, and only 10% said neither.
So what's going on here? Thoughts? Oh, okay, good question, Anna. Something funky. That would have been my term exactly, that the patient is having so many fractures, right?
I just want to say that I borrowed the last case study and also the following few slides from Carolyn Becker, who is Associate Professor of Medicine at Harvard Medical School.
So, reflections. Race was not mentioned in these cases, right? These cases did not mention race. Oh, okay, good. Right, domestic violence, or what else? Undiagnosed osteoporosis in the person. Okay. Well, race, as I said before, is not mentioned in these cases. Despite this, did you think of either patient in racial terms? Just the short descriptors. Did you think of either patient in racial terms? And if you did, what triggered you to think of race? I'm not asking you to write anything down, but just reflections, okay? And could these assumptions or biases have led you to incorrect diagnosis and or management of these two patients? Could any assumptions or biases lead you to mismanagement of both of these patients? Okay. Okay, right. Sickle cell, most likely African American. Okay. Now, what happened? Patient 1 was considered a drug seeker and had been sent home by the medical team on multiple occasions with inadequate pain medication, despite obvious distress during her crisis. She never exhibited any evidence of substance use disorder. Patient 2 was discharged by the orthopedic team with a 30-day supply of OxyContin plus 1 refill. She was never suspected of having a substance use disorder. Well, what resolution? Patient 1, during this third admission for sickle cell, the attending physician obtained additional history that patient 1 was under tremendous stress. Her only child, 20-year-old son, had gotten into trouble and was recently incarcerated. As a single parent, patient 1 could not afford to post bail and was extremely fearful about what would happen to her son. She was now referred to a social worker and counsel, and with their support, was able to post bail and place her son in a community-based program for at-risk youth. Her sickle cell crisis abated. Patient 2, after the humeral fracture, patient 2 received an extensive outpatient workup by a metabolic bone specialist and was treated with multiple medications for severe osteoporosis. Despite this, she continued to fall and fracture over the next 3 years. After her husband, just one husband, threatened divorce, she finally sought help for chronic alcoholism and entered a rehab facility. Her excess alcohol use was never suspected by any of her treating physicians, despite a strong positive family history. In fact, when they did ask her about alcohol use on the first admission, she said she drinks socially. And that was never pursued any further. But good thoughts that, yeah, it's a little funky that she's falling all the time, okay? You may have osteoporosis, but correct me if I'm wrong, that doesn't necessarily cause you to fall so many times. Maybe because you have weak bones, but a good thought to think about something else. So examining assumptions and biases, sickle cell disease in the US almost exclusively among Blacks when they were brought over as slaves from sub-Saharan Africa, right? Sickle cell was thought to be evolutionary positive trait if you live in Africa. Now, she works as a cashier at a discount store. Biases, lower class, working class, or poor with a chronic disease, stigmatized by pain and opiate use. Her disease plus the race plus the sickle cell and racism more likely to be considered drug seeking. Now, I would like to maintain, since so we have the disease. Well, I would like to maintain, correct me if I'm wrong, that if it was another disease and the patient was white, but low socioeconomic status and maybe some other attributes, we most would also consider that person to be drug seeking. Again, examining assumptions and biases. Patient 2, osteoporotic fracture, most common among white women, least among Black women, with Asians and Hispanics in between. She works as a literature professor at a university. Biases, upper class, highly educated, privileged, no stigma. Disease, osteoporosis, white race, high socioeconomic, white privilege, less likely to be considered drug seeking. Now, she wasn't, well, I can't say if this patient was seeking drugs or not. She got a 30-day supply when one refill. I don't think that actually happens. But anyway, examining assumptions, both patients were poorly served by implicit or unconscious biases held by the healthcare providers. Looking deeper, Black and white study of systemic racism, comparing sickle cell disease and cystic fibrosis. Okay, and the major thing to look at is, whoops, I pressed the wrong button there. Right, is that NIH funding, the difference, the philanthropy difference, annual publications, and industry-funded trials, 6.8 versus 15.6, drug approvals, 1, drug approvals, 4. And so that's the systemic racism part, where the institution, organization, society has, built-in unconscious racism. Now, I'm not going to talk about critical race theory, but looking deeper, well, let me end with this slide. So this slide, probability, well, let me see, is, I can't get, okay, right, let me go over this. In emergency rooms, Blacks with long bone fractures are less likely to be given any pain medications compared to whites, despite similar self-reports of pain. Blacks are less likely than whites to receive opioids opioids for severe pain, including pre and postoperative care, metastatic cancer, and non-cancer chronic pain. What's going on here? Nearly 70% of patients with sickle cell disease avoid seeking medical care due to vaso-occlusive crisis despite incapacitating pain. Why is that? Maybe they feel they're going to be labeled. Black children with acute appendicitis are less likely to be treated for pain than white children. So we go to the data. Probability of children with acute appendicitis receiving any analgesia for pain, and we see moderate pain, severe pain, and we see the difference in opioid analgesia. Okay, so well, I just wanted to clarify recent thinking about these issues, and I know you're all aware of it, but I think it's healthy to talk about it. And so, well, what's the outcome of this patient? Well, it's most likely she'll get a bed at Midtown, might become available this week. I don't know if any of the healthcare providers are going to ask the POA some of the questions I recommended, but you're right. It just seems like at every point there's a barrier going up, and so if you ask, did she explain why she's not pursuing a trach and a peg or an LP, blah blah blah, and she was very cryptic in her responses, and so maybe that's a telltale sign that she is not trusting the medical profession, and maybe she has had previous experiences. Okay, let me end here. Any final thoughts people would like to share? Final thoughts?
Anyone have thoughts or questions?
Yes, thoughts, questions.
That was a really good overview, Dr. Silverman. I think it's a really important topic that, is especially important here at University of Maryland with the kind of history that exists in Baltimore with healthcare disparities and also racial biases and mistrust, I think, with the healthcare system.
Yeah, right, exactly. I mean, you all know who our patients are, and West Baltimore, and it needs to be further investigated. In fact, I was thinking about. I was talking to someone. I've been talking to a lot of the folks who are leading diversity, equity, inclusiveness programs here on campus. And we were discussing about doing an interview study of hospital workers. I mean, they reflect the outlying community racial mix, and ask them what do they think about when they receive healthcare here? Are they concerned? What are the concerns? And we won't know unless we ask. And so that might be an interesting study to do. Okay. All right. Well, I appreciate you responding to the polls, and a lot of you, every one of you wrote interesting things in the chat back. So I appreciate the interaction because if there's no interaction, there's always a strong likelihood I might fall asleep. So that didn't happen. So anyway, thanks again for your attention. Okay. All right. Have a good afternoon. All right.
Thanks, Dr. Silverman. All right, everyone. Have a great rest of your day.